Welcome everyone to this afternoon's webinar. My name is Debbie Harvey and I'm the Primary Care Lead for Cheshire Merseyside Cancer Alliance. We're using Teams Town Hall this afternoon, which means that your camera will be switched off and you will be muted, but we'd encourage you to put any of your questions in the Q&A box. I'd also remind you that we have places left for the Red Whale educational sessions. If you scroll up to the top of the chat, you'll find the QR codes for those. The webinar will be recorded and will be posted on the Cancer Academy website in the next few days. And so it gives me great pleasure to introduce our speaker this afternoon, Dr. Martin Ledson. So over to you, Martin.
Thanks, Debbie. Afternoon, everybody. Let me see if I can successfully manage to share my screen. Can you see my first page?
That's there. Thanks, Martin.
Wonderful. So something's working at least. So hello, I'm Martin Ledson. If you don't know me, I'm a chest physician in South Liverpool. I am lead clinician for the Liverpool Lung Cancer Unit, which is a cooperation between the Royal and Liverpool Heart and Chest Hospital. And we should all have a cake because it's 25 years old this year. Not often that sort of joint collaborations work. And I'm also the responsible assessor for the Targeted Lung Health Programme. I'm going to talk for about 40 minutes, 45 minutes on lung cancer, and I'm going to dip in and dip out different aspects. And I thought more aspects primary care might be more interested in, but I'm certainly not going to teach my grandma how to suck eggs. I remember when I was a medical student, Clatterbridge on the Arrow Park site, on the Wirral site, had a lunchtime meeting, I think on a Tuesday lunchtime. And as a medical student as ever, you went there just because it was free food. And there was an old professor of gynecology who'd come up from London talking about a really rare form of gynecological cancer. And one of the wily GPs in the room said, if I work out the incidence of this, a GP will see it once in 2 average careers. Well, that's certainly not true of lung cancer, and you will all have lung cancer patients under your care. This is just a quick reminder of what our patients die of. And pretty much they're all smoking related, and the size of the bubble is the size of the deaths. So if you heart and circulatory disorders, cancer, of which lung cancer is a major player, and respiratory disorders by far are the biggest cause of death in our patients. And you don't need to be a rocket scientist to work out the cause. The cause of all of those conditions is largely cigarette smoking, and there is an absolute linear relationship between the number of cigarettes you've smoked and your chances of getting lung cancer. Now, the first cigarette making machine was developed in the 1880s in America. So before that, people chewed tobacco or smoked a pipe. We're all aware in the First World War, smoking was advocated amongst the troops, and they were sent cigarettes and tins and all sorts of things. And lung cancer incidence increased in men in the 20s, 30s, and 40s. But the tobacco industry realized by the Second World War they were missing out on 50% of the population. So there were massive advertising campaigns in the 40s and the 50s. And if you remember the kind of TV program showing 50s advertising, it's normally film stars with a cigarette in their mouth. And that meant females started increasing smoking during the 40s and 50s. And you can see the increase in lung cancer in women in this country with a 20-30 year lag coincided with the increase in smoking in the 40s and 50s. Oh, it's not projecting very well, this slide. Certainly in South Liverpool, I live in a very deprived area, and you can see Cheshire and Merseyside is quite variable in its deprivation indexes, with some very beautiful leafy parts and some very inner city parts. Lung cancer is strongly associated with deprivation. So this is a few years old now, but the figures haven't changed, showing relative standardized lung cancer rates in different areas in England. We can see in men, For Liverpool, it's more than 150% of the national average, but it's pretty impressive with women in Liverpool, over 200% of the national average. More interestingly, when we move on to some other figures I'm going to present, symptoms in lung cancer was done in a study based from Devon GP practices, and that's the southwestern area. So you can see there they have a very much lower than the national incidence of lung cancer, and I don't think respiratory symptoms there are as frequent as respiratory symptoms we see in Liverpool. I don't think I've ever met a respiratory patient who hasn't got a cough in Liverpool. This is the stage 4 diagnosis for cancers. Let's see if I can minimize that. I hope you can't see that. I'll move it out the way. And you can see lung is an absolute outlier. 50% of lung cancers at presentation present with stage 4 disease. So it's an enormous problem. The graph on the right also shows the incidence of the cancers and then the yearly mortality from them. And you can see you add up the next 3 cancers. So you can add up the deaths from breast, prostate, and bowel cancer, and you still don't get as many deaths as you do per year from lung cancer. So late stage at presentation, lots and lots of deaths. Probably about as up-to-date information you're going to get. So this is from the State of the Nation Patient and Public Report 2024. It's published in April, and it relates to diagnoses in England and Wales in 2022. So as ever, there were about 40,000 diagnoses of lung cancer. The mean age at diagnosis was 74. Nationally, and we'll come on to this a bit later, 1 in 10 are never smokers. In my practice, it's about 5%, and that's probably because I've got a disproportionate number of smokers in my catchment area. The figures haven't changed. 1 in 2 patients, 50% of patients present at stage 4 disease. 9 out of 10 are non-small cell, and about 1 in 10 in small cell. And this is another figure that's really quite shocking, is 1 in 3 patients with lung cancer present through an emergency route. They don't present with lung cancer, they present with nausea and abdominal pain of hypercalcemia, or a broken hip due to the MET, or signs of a stroke due to the MET. And that's a really shocking figure, and no other cancer presents through the emergency route like that. So these are my figures, April to April 2022-23, the Liverpool Lung Cancer Unit. So in that year, we diagnosed 516 new primary lung cancers. That's excluding the secondaries and the mesotheliomas. In that year, 22.5% were acute. So you might shout and say, oh, aren't we doing well? Way lower than the national average. That's because just about in that year, 21% of my patients were through the screened route. And if you take those patients out, the figure goes up to about 30%. So we're not doing brilliantly. Of the people who present acutely, it really is a dire picture. A higher proportion have got small cell. More than half of them we don't get tissue on. It's a clinical diagnosis, and a very high proportion of them have got stage 4 disease. So emergency presentation is a route really to palliative care in the majority of cases. In 2019, NHS England announced its quite ambitious long-term plan for cancer, and they wanted to have a lot more survival at 1 year, and they also want to increase early diagnosis. And it was really from that and other things that they started to think about lung cancer and how do we detect lung cancer at an earlier stage. And they started having conversations about lung cancer screening and targeted lung health checks. We'll talk about these in some detail in a little while, because I think they're a really important step in helping to manage lung cancer. First of all, there were 10 pilot sites, of which we were 2 of them. And I'll talk you through what happens in a targeted lung health check. Many of you in the audience will already have those programs running in your areas, and we hope to cover the whole of Cheshire and Merseyside within the next year or so. But I'll just talk you through both my and England's history of lung cancer screening. So the only and first UK lung cancer screening trial was the UKLS. and that was run out of Liverpool University and the Liverpool Heart and Chest Hospital by a guy called John Field, who's one of the professors at the university. What they decided to do was use a new lung risk cancer prediction model called My Lung Risk. So all of you who are now having your lunch and bored, just go on your smartphones and on Google, just type in My Lung Risk, and you can quickly work out either your lung cancer risk or your wife's or your partner's or family and friends. They screened 1,000 people to CT in Liverpool and 1,000 people to CT in Papworth in Cambridge. And they were very deliberately chosen because Papworth is lovely and leafy and affluent and beautiful and green. And Liverpool, per se, didn't tick any of the above boxes. And we wanted to target two different entirely populations. The overall pickup rate was about 2%. But it was 2.4% in the Liverpool population, which isn't a million miles away from the nice guidance of refer at 3%, except these were an asymptomatic population. And more interestingly, rather than 20% being offered curative intention treatment, 80% were offered curative intensive treatment. So in 2011 to 13, I was sat in our cancer clinic at Liverpool Heart and Chest Hospital, and patients with results had come through, and it would be, you know, A&E, go and see palliative care, go and see the oncologist. A UKLS patient, go and see the surgeon. A UKLS patient, go and see the surgeon. It really was chalk and cheese, and it made you feel if you waited for lung cancer patients to come to you, you were far too late and you had to go out and find them in your population. And it was because of that we started having conversations about lung cancer screening programs. We actually first went to Knowsley, but I won't continue that conversation. And then very quickly by 2014 had gone to Liverpool, and with the help of their lead lung cancer GP, Ed Gaynor, we persuaded Liverpool to start the Liverpool Healthy Lung Programme. And that ran from 2016 to 2020. And as COVID hit, we had literally just completed our first sweep of the city. Amazingly, more than 70% of the people who were screened had early stage cancer and were offered curative intent. So lung cancer screening works. I always get very vexed when on the TV, it's always about the Manchester Lung Health Check pilot. I'm not belittling it in any way, shape or form, but ours was much bigger and much longer, and I think much better. But anyway, I'm not biased at all. So from that, we were then canvassing. I remember Ed, John Field, and myself went down to the Lung Cancer Screening Committee in 2000, I think it was 18, and really pushed hard for lung cancer screening. And it was amazing in 2018 how much negativity there was about lung cancer screening. But with the cancer plan and different politicians, it was decided the only way we were going to change national statistics on cancer was to introduce lung cancer screening. And we might talk about it later on, but the cost-effective models have suggested it's probably the most cost-effective screening program there is in the UK at the moment. Phase 1 was Halton and Knowsley. Phase 2 added in the existing screening program, so Liverpool was added in. Phase 3, which started about 18 months ago, was South Sefton and St Helens, and imminently later this month, Phase 4 is about to begin, which starts in the Wirral, but then quickly moves to Runcorn and to North Sefton. What happens is it's led by the Liverpool Heart and Lung Hospital. We invite people either by text or by letter. It's people between the ages of 55 and 74 who've ever smoked. The list is derived from GP practice lists. At that lung health check, which is virtual, unless the patient needs a face-to-face, when we do have some face-to-face components, we go through exactly what we did in the Liverpool lung health checks, and that's no accident. They mirrored what we did. So we go through a patient's lifestyle, we go through their weight and their exercise, and we can signpost them to nutritional advice or gyms or exercise programs. If they've got a label of COPD, we do a COPD health review and an inhaler check. If they haven't got a label of COPD, they're referred for spirometry. We then do 2 risk scores with the national programme, the LLP, which is the one we used for the Liverpool Healthy Lung programme, but also one called PLCO, which is a Canadian risk score. And NHS England have set the risk score at half of what it was for the Liverpool Lung Health project. So one might expect you'd only find half the cancers and screen twice the people. And that was deliberate to get population coverage. And those who trigger a score are offered a CT scan on a mobile van, normally in a supermarket, very close to where they live. So the whole program's used a local risk stratified approach, certainly in terms of the phases we're rolling out, but even within an area, we tend to target practices with the highest deprivation and highest lung cancer risk first as we move around that area. As I say, GP practices identify the data for us. Just running through those areas. So as we saw, Liverpool has more than double the national average of lung cancer, but look at Knowsley, Holton, South Sefton and St Helens all feature very highly. I say the mobile vans and the project's about to get a 3rd mobile scanner now go around local supermarket car parks, and we have the spirometry van situated next door to it in phase 3, so the patients don't have to travel for their scans. When we were about to start the Liverpool Healthy Lung project back in April 2016, I had, a bit like when we started Straight to CT, which we'll tell you about, I had a few sleepless nights. So what we're going to do is invite hardened Liverpool smokers to a lung health check, where we're probably going to tell them they're overweight, they don't exercise enough, where if they're very lucky, going to do spirometry, that will give them COPD. And 10% of the people in the Liverpool programme who didn't have COPD when they arrived did have COPD when they left, because COPD is massively underdiagnosed. And then if they're really, 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 really lucky, we're going to give them COPD and we're going to give them lung cancer. I thought, this isn't going to be very popular, but actually the feedback from patients, this was a really positive healthcare experience. They engaged well with the nursing team. They felt this was a good opportunity to increase the overall health, to maximize their lifestyle and certainly focus on their lungs, and consistent feedback throughout. And if you look at the Ipsos Mori polls around our lung checks done under the national programme, again, we're top of the board, and the patients find this a really, really valuable healthcare experience. I won't dwell on what the patients said. This is, and Debbie will recognise this, how the data is presented at the steering group. So I've just picked out phase 3, which is the phase we're currently in, to give you some data of the scale. So in phase 3, there were 42,000 invitations. So far, about 21,500 have taken up the appointment of a lung health check, which is over 50%. The national average is just short of 40%. Now, we changed after phase 2 and just at the start of phase 3. If you just invite patients, about 40% turn up. If you offer them the appointment date and it's an opt-out model, uptake goes to more than 50%. So that's the model we've continued. Again, about 60% trigger the risk score and convert to a CT scan. The national average is about 40%, which just shows us how high risk and deprived the patient population is in the areas we're visiting. We've done about 13,000 first CT scans. Now, the bottom 2 lines are progress in action, because it takes time for the cancers to be identified. But you can see from that, and maybe I'll quote phase 1 and 2 figures at this, about 2% get a cancer referral. I think at the end of all the CTs in phase 1 and 2, about 1.2% were diagnosed with cancer. 80% of them are offered curative treatment. And again, there is no other cancer screening program that gets those sort of numbers. There's about 0.6% of people who get referred for another cancer and not lung cancer, because when you screen from bottom of the neck all the way to mid-abdomen, you find a lot of other things. We work very hard to minimise actions and secondary care referrals, and all lung nodules are followed up in the project. But the numbers are huge, and I think to date about 120,000 people have been invited in our local project. Any queries that the number? Again, it doesn't project very well. I think the main success of the Targeted Lung Health Program is the pin-up they've used, and you can see he's handsome. And wouldn't you want to take part after seeing that? More, the question for you is, in your GP practices, how do you identify people with lung cancer? They've all got respiratory disease and they've all got a cough, and most of them aren't well when they come and see you. So how can you identify people with lung cancer? It's nigh impossible, isn't it? NICE 2015, updated in 2021, suggested if a chest X-ray suggests lung cancer, refer in, and 40 with unexplained hemoptysis. Remember, it used to say persistent, but they didn't define persistent in the older guidance. And then everything leads to a chest X-ray, really. So a chest X-ray should be done if you've got 2 or more expected symptoms, but only 1 or more if you've ever smoked. So that's the first divide they start putting in, thinking you don't have to have smoked to get lung cancer. And if you've got 2 unexpected symptoms, do an X-ray. Think of doing an X-ray. There could be something respiratory going on, even if it's cough, fatigue, breathlessness, chest pain, weight loss, appetite loss, clubbing, nodes, chest signs, thrombocytosis. So X-ray is the mainstay of what you need to do. If you've got any hint anything's going on, please book a chest X-ray. NICE guidance says if there's a risk of 3%, they should be referred through a cancer route, whether these days that's a rapid access test or whether that's a rapid access referral. But they note only smoking and age are predictors of whether you're going to get lung cancer. So there's no symptoms, particularly in that statement. So this is this study that was done in Devon in 2005. Reasonable sized numbers, and in Devon GP practices, if you had the following symptoms, that was the predictive value of whether you're going to be diagnosed with lung cancer. So you can see absolutely none of those reached the 3% threshold. If you've got hemoptysis, which is the highest one, it's 2.4, and even that's kind of unexplained hemoptysis. But there's things in there that you don't necessarily think of: the spirometry value, thrombocytosis, and some very, very non-specific symptoms that wouldn't necessarily make you think of respiratory illness, like lack of appetite or loss of weight. The funny dashes and pluses next to that are from 1999, when we formed the Liverpool Lung Cancer Unit, to 2014, we had a one-stop rapid access model. And people referred in, these were what happened with the prediction of lung cancer. So if you were referred in with cough, which is not very specific for lung cancer at all, it's bottom of the pile, that had no influence whether you had lung cancer or not when you came to our one-stop rapid access clinic. If you got loss of weight, loss of appetite, chest pain or dyspnea, it was a positive predictor. We were going to find lung cancer in you. If you were coughing blood, it was a very large negative predictor that you were almost certainly not going to have lung cancer, because we got a disproportionate number of hemoptyses. So it sort of depends where on the pyramid you look at the patients as to the predictive value of lung cancer. Do you remember the mouse mats? This didn't photocopy very well, but this was the mouse mat I was given in 2013, where the National Cancer Action Team tried to put all the symptoms together to try and get symptom conurbations that got you over the 3% threshold, and you could refer. And you can see most of it never even with 2 symptoms or 3 symptoms or 4 symptoms, never made the 3% threshold. And it's moved away from that very quickly. I certainly remember when I was a registrar at the Wirral, just before I got Calmanised, the Wirral ran a very, very large primary care cough campaign. And I think it ran for 6 months with lots of extra appointments. And I think at the end of the 6 months, people from the Wirral can quote me, but they hadn't found a single case of lung cancer. I'm sure they found lots of infections and COPD, but they hadn't found any lung cancer. At this point, I always just pause and think how daft the NHS is. So smoking causes peripheral vascular disease, ischemic heart disease, COPD, and lung cancer. But they're completely different silos in the NHS. And at your peripheral vascular disease clinic, they don't screen you for lung cancer or make sure you've had spirometry for COPD, nor do they look for ischemic heart disease at your lung cancer clinic. Yet it's all the same patients. And when patients come through our lung cancer service, you can bet your bottom dollar on the GP record. It says peripheral vascular disease, previous MI, known COPD, and how the NHS can work in such a fragmented way always befuddles me. But anyway, that's my rant over. So the patient presented with symptoms. You said, oh, you've got a cough and you've lost a bit of weight. Let's send you for a chest x-ray, and it's abnormal. Jobs are good, and on the left shows a big mass at the left hilum. Aren't we good doctors? The rest of it's easy. More challenging is what you do in nearly all the cases when you do that and the x-ray comes back as normal. Well, reassuringly, normal probably means it's normal. An x-ray sensitivity isn't very good for predicting lung cancer. It's about 80%, but it's got an extremely good negative predictive value. It's not 100%, but it's 99.7. And in a reasonably large study, they took all those normal x-rays and followed the patients up for 2 years. And in a 2-year interval, only 0.8% of the patients had developed lung cancer. So largely, a normal x-ray is a normal x-ray. GPs in the same period we've always talked about with the data, 2022 to 2023, ordered 2.1 million chest x-rays, but that's still far behind the number of x-rays ordered in many of the countries of Europe. An x-ray is accessible, it's cheap, we can get radiographer reporters and non-medical reporters, and the turnaround time's quite quick. So chest x-ray is still the absolute gold standard when it comes to kind of, for want of a better word, screening for lung cancer in symptomatic patients. The national lung cancer awareness campaigns, or cancer awareness campaigns, I can't go in a gent's toilet these days without the little symbol, if you've got blood in your pee, please have a word with your doctor, have focused on cough. Now we can debate whether focusing on the least predictive of lung cancer symptom was the right one to focus on, but it is interesting that the number of x-rays ordered goes up by about 19% when those campaigns are running. Is that triggering primary care's mind, or is that triggering patients' minds to go and get some help? Interestingly, there isn't really a stage shift during those periods of national campaign, but certainly it focuses us, and we do a lot more chest x-rays. Is one way forward non-medics ordering chest x-rays? Should our practice nurses order chest x-rays? Should pharmacists order chest x-rays? Should there be a sign next to the cough suppressants in a pharmacy, or when they come to the till at pharmacy buying a cough suppressant, should there be a quick intervention asking about the cough and ordering a chest x-ray? Leeds and Nottingham have certainly done direct patient access for chest x-rays. If you're over a certain age and you've smoked and you feel you need an x-ray, you can just self-book yourself in and get yourself an x-ray. All these things need to be considered, because getting more patients to x-rays is probably one of the keys of finding more cases of lung cancer. We'll talk about cancer pathways in a minute. Many of you now will probably have direct access to CT. Certainly, I think that should be used for hemoptysis. I certainly think there's also, if your chest x-ray is suspicious of lung cancer, there should be a direct mechanism to get you to CT. It probably shouldn't be used for the other symptoms. And I think, like the mouse mat, we probably need to derive an algorithm that says chest x-ray normal, but clubbed, weight loss, lock of appetite, high platelet count, need a CT scan, over 70 smoker. But there should be criteria that increase those risks. And I've had just an observation. We've had a little run at the moment with our straight to CT pathway, where the clinical information is non-smoker, persistent cough, normal x-ray. Well, you're taking a lowest symptom possible with the lowest risk patient possible with a normal x-ray that we've said is 99.7% positive negative predictive value. They're probably not the population that need to go on for a CT scan, but I'm more than happy to discuss that, because it's contentious and there's no easy answer. In 2000 and I want to say 19, NHS England produced the optimal lung cancer pathway, and the forefront of that is straight to CT. Now, Liverpool, I know you're from Cheshire and Merseyside, I don't want to focus on Liverpool too much, but Liverpool, of course, designed one of the first lung cancer screening programs, and Liverpool started its straight to CT program in 6th of January 2016. And certainly when they were designing the National Optimal Lung Cancer Pathway, the lead of that was a chap called David Baldwin, who's a professor of respiratory medicine, came up to Liverpool and discussed our pathway. And the optimal lung cancer pathway is again a mirror of the Liverpool pathway. So what happens in my neck of the woods is any image that's suspicious of lung cancer, the radiographer or radiologist just puts an alert on that says this is suspicious of lung cancer. That's been happening since 1999. If that's a CT scan covering the whole thorax, nobody ever has to refer anybody to the lung cancer team. The lung cancer team just take those patients immediately. If the chest x-ray or other image that isn't a CT thorax suggests lung cancer should be present, it's an automatic within 3 days CT scan organised by radiology. And if any primary care physician feels lung cancer is high on the agenda, they can also order a 72-hour CT scan. All CT scans suggestive of lung cancer are just automatically taken by the lung cancer team. CT scans done under that pathway that don't show lung cancer go back to primary care, who just tend to quickly telephone the patient and say everything's fine. What that does is, for the vast majority, about 70% on my pathway, they haven't got lung cancer. They don't need to enter a lung cancer pathway. They do not need to be scared to death. They don't need to come up to a hospital and see a chest doctor, and they can be reassured very quickly. And that means all the effort and intensity of the lung cancer team is then focused on patients with lung cancer, not making sure people don't have lung cancer. And it's about 60% cheaper and 60% more efficient. So I'm a big advocate of a straight to CT pathway. There was last year a big meeting about trying to develop strategies for lung cancer in non-smokers. And as I say, nationally, that figure's about just short of 10%. And the group raised kind of 4 different brackets that need to be considered. How to raise awareness. Is there such a thing as risk assessment and early detection? Is the disease biology different in the non-smokers? And is survivorship and living with and beyond different in the non-smoking population? Certainly, we're aware there is a genetic component to lung cancer in non-smokers. It tends to be females and those of Southeast Asian extraction. Certainly a big component is pre-existing lung disease. So the presence of pulmonary fibrosis is a major risk factor for developing lung cancer. Less so in the UK, but more so in the rest of the world is the environment. So we don't have many females in Liverpool who weld in enclosed confined spaces, but certainly in many parts of the world, cooking is done over an open fire in a very enclosed space, and that can be a risk factor for lung cancer. So certainly in places like Korea, who've got lung cancer screening programs, non-smoking family history and environment and pre-existing chest disease take higher component in score allocation than some of the things we put in there. Certainly, I get patients coming to clinic and saying, oh, it must be genetic. My dad had lung cancer, my brother had lung cancer, my sister had lung cancer. And when you quiz them, they were all heavy smokers. So certainly in the heavy smoking population, smoking is by far the biggest risk factor, not genetics, but work in progress. I'm going to focus for a little bit now on what's changing in lung cancer. And lung cancer is very, very exciting at the moment. And there was lots and lots and lots of nihilism 10 years ago about lung cancer. Patients were elderly, they had significant comorbidity. Mean survival with lung cancer was 9 months. Patients didn't want to bother because the diagnosis and the treatment was worse than just ignoring it. A lot of healthcare physicians didn't really feel lung cancer treatment and diagnosis had a massive place in some of the more elderly, frail patients. patients. And we now live in a very, very different world. This is a VATS lung resection. One of the more than 90% of lung resections now are done through minimally invasive approaches. And you now have your lobectomy with a mean length of stay of 4 days, which is utterly, utterly unbelievable. What other changes have occurred in the last 10 years? Well, for the last 10 years, we've had immunotherapy, which again have revolutionized lung cancer management. But what it does mean is to be eligible for immunotherapy, we have to get adequate tissue to do the genetic markers to see if they're going to be eligible for it. So that means the onus is on me as a chest physician to get as much tissue as I can on these very frail, elderly, significant COPD, poor pulmonary function patients, because these days that can really make a difference between treatment and no treatment. In 2000, so only last year was introduced neoadjuvant treatment. So there's now some evidence at certain stages with non-small cell lung cancer, giving immunochemotherapy before surgery can have quite a beneficial outcome in survival. We'll talk a little bit about SABR, so intense radiotherapy to nodules. EBUS bronchoscopy has revolutionized staging of the mediastinum. And it's not that long ago, just before my career, people were operating off the back of a chest X-ray. And now with an EBUS, we can accurately stage the mediastinum, which means we're accurately knowing the stage of the patient, which allows them to have surgery or neoadjuvant and then surgery, or concurrent radiotherapy and it shrinks and then surgery. And we've already talked about the screening program. So the molecular markers, the commonest one you're probably going to see in your letters is EGFR, occurs in about 10% of Caucasian people, a lot higher in people of Southeast Asian origin, but there's lots of other markers. And if you get one of those markers now, many of the cancer treatment pathways at Clatterbridge, which I'm not going to talk about, I'm not an oncologist, will involve immunotherapy, and they now have specific immunotherapy clinics, but the results of immunotherapy are significantly better than standard chemotherapy. Often patients get combination treatment. So we've got people coming forward, we've got screening at an earlier age, we've got neoadjuvant therapy, we've got much better oncology treatments. And at the moment, it's revolutionizing the way people are managed with lung cancer. And I now get letters from the oncologist, this patient you diagnosed with stage 3 disease 4 years ago is doing well, which is absolutely brilliant. Neoadjuvant treatment, so it's for people with stage 1B to 3A non-small cell. So we diagnose them, they see the surgeon says, yes, we can resect this. They then go to oncology for chemoimmunotherapy, and it's got much better survival rates. SABR is brilliant. Again, if you've got a nodule, but you've got significant comorbidities or you've got significant COPD, which limits what you can do to a cancer and surgery is not possible, the oncologist can now give high dose radiotherapy to a relatively small nodule. And it's almost as good in terms of outcome as surgery. So we certainly use that a lot in our more frail or our more spirometry restricted patients. SABR only applies to certain cases and certain stages, and it can't be done near major vessels or major airways. But this slide, I just wanted to highlight a lot of the trials done in lung cancer management pick performance states 0 to 2. But of course, if you live in city centre Liverpool, many of our patients have got significantly worse performance states than that. However, performance state can be a variable feast, and you can improve the performance state of many patients with appropriate bronchodilators and exercise. The final slide, and then we can throw this over to conversation, is how are we going to cope with staffing shortages? You've got no staff, we've got no staff, nobody's got any staff. One we might debate, but it certainly means that cancer recognition and treatment systems have to be absolutely as efficient as possible to minimize that staffing use. Thank you very much. I will, if I can, end my sharing. And go back to the normal screen. Welcome any questions.
Thank you, Martin. We don't have any questions or Q&As that I can see. I guess a reflection from myself is certainly working in primary care, we absolutely need to make sure that we've got our smoking status as refined as we can be. That's so important with targeted lung health checks. And I think also that reflecting on what you've described this afternoon, thankfully able to offer an awful lot more hope to people with lung cancer, with the certainly with the targeted lung health checks. You know, that switching stage is phenomenal, really, and the fact that so many people are now offered curative treatments, and I imagine that that's probably a highlight of your career, because I think lung cancer, certainly as a GP who's been around for a while, has always been quite sadly a bit of a depressing disease because people fare so poorly. So I don't know what your reflections would be on that.
It's very exciting, and when we started the Liverpool Healthy Lung Project, my aim wasn't to find cancer, it was to change the messaging around lung cancer and try and remove that nihilism, because lung cancer is just as curable and treatable as any other cancer. We just got to manage it in the same way.
Yeah. And I think also your point about cough is really interesting, isn't it? Because cough is impressed on all of us as something to look out for. And that's quite often a really difficult one to pick out, you know, in our patients. So I work in Bootle, which is a deprived area. Every other patient that I see has a cough and has COPD already. So, and also generally from health, that their health isn't that brilliant either. So, so yeah, so it's quite interesting, the whole cough business, isn't it?
Yeah, but please do the X-ray, and you
Yes.
do. It's just where that cycle stops.
Yeah. And interestingly, with certainly for primary care and the plans that we have at the Cancer Alliance, they are encouraging us to use chest X-ray as the first diagnostic, particularly in non-smokers, because I think sometimes we perhaps overlook that cohort of patients, and there may be delays, you know, in their diagnostic workup. So I think for us as an alliance this year, obviously we have the targeted lung health check, which is gradually rolling across Cheshire, Merseyside, but we also can't forget about the non-smokers. So that's
Absolutely.
what we're encouraging our colleagues
on the
to
straight
do.
to CT pathway, I always make a point. This is the science we've talked about, but there's the art, isn't there? And if you, in your gut, think something's up with a patient, just use the straight to CT pathway, because your gut is more often right than the science.
Yeah, absolutely. Okay. I'm just double checking. So someone's asking, can the slides be sent to us yet? The webinar is being recorded, so that will be available for people to view. And I'll just check the Q&A box. No questions there. So I think probably everyone's questions have been answered, Martin, in your brilliant presentation. So thank you very much for your time.
Thank you for having me. Feel free, if there's a lung cancer issue, feel free just to reach out, or if you need to contact about the Targeted Lung Health Programme or anything, just reach out.
Brilliant, thank you. And just a final reminder from myself, we have a Cancer Academy, which is currently being refreshed and hopefully a lot easier to navigate. We have 3 separate venues for Red Whale in June, and there'll be other webinars planned for the remainder of the year. And please get in touch with us if you have any queries around cancer and primary care. Thank you, everybody. Good afternoon.
Thanks, Debbie. Bye-bye.